start. Well, thank you everyone for joining. Dr. Kathryn Ross is an associate professor in the Department of Clinical and Health Psychology and in the Social and Behavioral Sciences concentration in the College of Public Health and Health Professions. Dr. Ross currently teaches within the Social and Behavioral Sciences concentration in the M.P.H and Ph.D. in public health programs, and advises master's and doctoral students, both in the Department of Clinical Psychology and in public health. Dr. Ross's research focuses on the prevention and treatment of adult obesity, with particular emphasis on improving the long-term maintenance of weight loss and developing effective behavioral weight management interventions that can be disseminated on a public health level. Increasingly, she has begun to investigate the integration of newer technology into weight management interventions as a way of lowering cost of treatment, delivery, and increasing intervention reach. Thank you very much, Dr. Ross.
Turn my mic back on. Hopefully this works. Can y'all hear me okay out there too? And I apologize for the delay in the setup. There was an exam scheduled right up until noon in this room, and so we're doing what we would have done earlier now. And if I run through time, I'll just speed up a little bit. I'm good at talking fast. So as a bit of an overview for what I'm going to talk about today, I'm first going to give everyone an introduction, kind of who I am, where I'm coming from with this research, describe behavioral weight management interventions, some of the remote approaches that were available pre-pandemic, what we've done post-pandemic, and then wrap up with some implications for future work here. So first off, my background is in clinical psychology. I also have, just showing the right, nope, not even the right slide, okay. My background is in clinical and health psychology, and I also have some master's level work in biostatistics and public health. I direct here the UF Health Promotion Lab, where we do work on the prevention and treatment of adult obesity and obesity-related comorbidities such as type 2 diabetes, cardiovascular disease, and some cancers. And there are a few different areas that I focus in for my research, but three I'm going to kind of briefly go over, and then one I'm going to deep dive in today. So first, I'll be talking about behavioral interventions, and they are shockingly consistent at producing initial weight loss, not so great at helping people maintain weight loss long-term. It's been considered the Achilles heel of our area of research. And so one area that I do a lot of work in is how to improve long-term weight loss maintenance, how to help people keep weight off long-term. Another area of work that I've done is how to integrate newer technologies within behavioral intervention. So self-monitoring technology, wearables, those sorts of tools. And then finally, I've done some work in remote intervention delivery, which I'll talk about today. So first off, just to introduce behavioral weight management to make sure that we're all on the same page when I'm talking about this. These programs are typically delivered face-to-face. They're often in an individual or group-based format. There's some research showing that even for people who prefer individual, group tends to outperform. And they have, per current guidelines, at least 16 initial sessions. Historically, they've ranged in length from 3 to 12 months for the initial intervention, but we've kind of coalesced around this being a minimum in our current guidelines that were developed by the American Heart Association, or the College for Cardiology, and the Obesity Society. And in these 16 sessions, there are 3 core components. One, helping folks decrease their caloric intake, different calorie goals based on starting weight. Next, helping folks increase their engagement in physical activity, primarily moderate intensity physical activity like brisk walking. And this is really important for maintenance, more so than initial weight loss. And then use of behavioral skills training throughout those 16 sessions to help people learn skills to meet those goals. So things like problem solving, goal setting, using social support, stimulus control, all things to help people meet those behavior change goals. And they produce, on average, clinically significant weight losses of about 7 to 10%, coalescing kind of around that 8 kilograms, which for most studies translates to about 8% of weight loss from baseline weight. And our interventions I mentioned before are kind of shockingly consistent at producing this weight loss. And reductions of these magnitudes, the reason I call them clinically significant is that they lead to reductions in reducing the risk of developing type 2 diabetes by 30 to 60%, lead to modest reductions in fasting plasma glucose, HbA1c, and fewer medications needed in adults with type 2 diabetes. And then in addition to diabetes, we also see benefits in terms of cardiovascular disease risk, such as cholesterol, systolic and diastolic blood pressure, and also lower risk for future antihypertensive medication use. So these programs are consistently effective, but are still not widely available for most folks. There are large barriers to dissemination, including the cost of implementing these interventions, the need for trained staff, trained interventionists to deliver these interventions. And for most of the past 15, 20 years, unless you happen to live within driving distance of an academic health science center where there happened to be a researcher doing these sorts of interventions for their trials, you probably didn't have access to these treatments. And so I'm going to talk about 3 different approaches today to remote delivery of behavioral intervention: telephone-based approaches, internet and smartphone approaches, and then video conferencing, some of the newer work that we're doing. First off, the telephone-based interventions. This is kind of what was known pre-pandemic, what we had going on. 2 trials demonstrated similar outcomes for telephone calls versus face-to-face groups looking over time. And then 1 fully powered equivalency trial found no difference in outcomes between phone and face-to-face groups in primary care settings. So phone interventions have a lot of potential for helping spread these programs in terms of the limitation of trained providers, because a trained provider living in a town like Gainesville can then offer intervention to folks living just about anywhere via the telephone. They've also tend to be pretty cost-effective approaches to deliver an intervention. And importantly, I mentioned earlier, I do a lot of work in maintenance. Phone-based extended care interventions have been demonstrated to be able to successfully reduce weight regain after initial weight loss. And so extended care interventions are interventions where after the end of those 16 sessions or the end of the initial program, programs continue to provide support to folks longer term. Typically, this is about once a month. If it's a group-based intervention, they'll meet with their group again, meet with their interventionist, check in, see how things are going, get some additional support. And this falls under the chronic disease model of obesity, kind of taking that approach that obesity necessitates long-term treatment. It's not something you just give someone intervention and then you're done. That we provide intervention over time. And 1 study in particular I want to talk about, this last one was done with Dr. Michael Perry. He's on the Zoom call today, I can see, looking at extended care for maintenance of weight loss in rural communities using telehealth via phone. This was a randomized controlled trial of 3 extended care maintenance conditions. It had an initial weight loss program delivered through cooperative extension offices in medically underserved rural counties in Florida. And then people were randomized to 1 of 3 groups. I'll show that in picture form, so a little easier to see. So an initial 16-week weight loss program, then folks are randomized to receive 18 phone sessions, 18 group phone sessions, so teleconferencing, or to receive the same intervention content that was discussed in those calls, but via email or the snail mail if folks didn't have email. And then for the latter part of the study, I should say 17 through 22, there was a no contact follow-up period, which this is, side note, added by the study section request. Under the continuous care model of obesity, we would never say, well, now you're done, go on. But they wanted to kind of see the durable effects once treatment was removed in this condition. And so I'm bringing that up to talk about it'll put some of the context, put some of the results later in the context. So 445 adults with obesity were randomized to this trial, about 55 years old, about 3/4 non-Hispanic white, and about half had a high school degree or GED or higher, and about half had incomes less than $50,000 a year. And average phase 1 weight loss, what we would expect given our past studies, about 8 kilograms, which translates roughly to 8%. And so looking at changes by group over time, there were no initial changes between individual group or education during the initial intervention. During phase 2, that period where everyone's getting active intervention, the individual group had pretty much no weight change. That confidence interval, or in this case, is Bayesian, so criterion is crossing 0. Group 1, the group telephone counseling group gained about 1% over the course of that follow-up period, and then control about 2.6%. And then we take it out to that full period, so including that no contact period, that was the primary trial endpoint. We see a significant difference between the individual group and the control group, such that control gained almost twice what individual gained over that total period from the end of initial intervention all the way to the end of the no contact control period. And I do want to take one moment to kind of sidestep from talking about the effectiveness of this trial and its results into a secondary analysis we did of these results. I think it makes an important point moving on in this field. This was a paper that was led by Dr. O'Neill and IFAS here, looking at differential impact of telehealth extended care programs in African-American versus white individuals. And this was a follow-up of a study that we worked on from a previous weight management program in rural areas that found that extended care was differentially helpful for African-American versus white women, such that extended care only seemed to benefit non-Hispanic white women, which is an equity issue in our area. So we wanted to see how that was playing out in a larger sample, and a sample that had more African-American participants. This study included 410 adults from a rural LEAP trial who identified as non-Hispanic African-American or non-Hispanic white. And in phase 1, African-American participants lost less weight compared to white participants, which is historically observed in our literature. And there was no difference in weight regain overall during the extended care period between African-American and white participants. But importantly, there was a differential effectiveness of extended care during the extended care period. And I'll explain that in the next slide. I'll kind of break that interaction down. And it was such that there was a different pattern such that I got it here. Individuals who were white, we see a similar pattern to what we saw in the overall study. Individual group did best. They regained significantly less weight than control, with group kind of in between the middle. We see a different pattern for Black and African American adults, such that there was actually no statistically significant difference in weight regain by condition. But if you look at that pattern, we almost see an inverse of the pattern over here. Folks in the individual condition actually did the worse than control, whereas individuals randomized to the group condition did the best in terms of maintaining weight over time. And so these results, combined with the paper that I mentioned earlier that we did from one of the previous rural studies, suggest that African-American participants might not be receiving similar benefit from these sorts of extended care programs. And that future research should focus on methods to improve the efficacy of extended care programs for African-American participants. And some quick suggestions that we had offered through that paper: group interventions might be a method. Dr. O'Neill is doing some interesting work there, but that's what these results had suggested. Dr. Shriki Kumanika is doing some great work in terms of cultural tailoring for this population. And then Briggs and Fitzpatrick have been doing some community and family-based interventions that have been showing some good outcomes. But the reason that I went down this kind of side trail, and I wanted to bring this paper up, was that historically, a lot of the results I'm going to present today are done on populations that are largely non-Hispanic white, largely women. For a while in our field, there were studies that were only women. And so this is a problem because we're not able to assess whether our interventions are equitable in terms of their outcome for different population groups. And so this is just a quick side note to say that these interventions, we need to be careful as we're designing things in the future, that they're adequately powered. And not just in terms of like ensuring representation of different populations. So we see that a lot in grants now, that, oh, we're going to mirror the demographics of Gainesville, or we're going to mirror the demographics of the United States. That will often not lead to statistical power to test these comparisons in groups, and is also not recruiting individuals based on who's actually at risk of some of the underlying health conditions. And so this is just a kind of side soapbox note to note that for our future studies, we really need to make sure that we're able to investigate differential outcomes and focus on how to improve our interventions so that our outcomes are more equitable. So moving on to internet and web-based interventions. I'm going to give some results from a review paper we worked on with some colleagues from SBM. Overall, taking a broad look at the internet-based literature, we found that there are clinically meaningful weight losses in terms of some of the health outcomes we see from these weight losses, but they're smaller than those typically observed in in-person interventions. As I mentioned, the 7 to 10%, around about 8% typically seen in person. There's also a very wide variance in these outcomes. And this is due to heterogeneity in the intervention components offered. Put it simply, everyone's kind of doing their own thing. And you get a lot of different results when you have groups designing their own interventions from the ground up and including different components. And there has been an interesting kind of shift in efficacy over time, however, such that some of the early interventions, primarily using static educational materials, we were all excited about the internet, so we put our treatment materials up on the internet. We thought that'd be effective. Turns out not that effective. People aren't going to read it. Education alone, we know, doesn't do much to change health behavior. So these programs were largely ineffective. But efficacy of these programs increased over time by adding interactive lessons, tailored feedback, and some of the smartphone apps even broke down lessons into 10 to 15 minute snippets. They'll have quizzes embedded. They'll make sure that they feel more like a group intervention or an even individual intervention, but in person. So the efficacy has been getting stronger for these over time. And to bridge that out to smartphone interventions, because it's kind of the new era of a lot of folks are accessing the internet through their smartphones anyways. So some of the internet interventions can even kind of be seen under this broad umbrella. There was a meta-analysis done recently that found that smartphone apps similarly produce a weight loss that's smaller than what we'd expect in in-person programs. With that said, this study grouped a wide variety of smartphone apps. And one of the challenges with the apps is similar to the early internet interventions is everyone's doing their own thing. Plus, a lot of these apps tend to focus on a very specific piece. So there's a ton of apps that let you self-monitor your caloric intake and your physical activity, but don't necessarily offer problem-solving, goal setting, some of the other intervention components. And so those might be, I'll mention a little bit, I'll go ahead and bring the slide up, better considered as tools and not interventions in and of themselves. And there's been a couple studies now looking at the use of some of those self-monitoring apps, some of the wearables. We all got excited about Apple Watches and wearable fitness trackers for a while. They can be really great as tools. They are unlikely to produce especially sustained behavior change in and of themselves just by use, but in the context of a broader intervention can be helpful. And so it's important to, as we move forward as a field, also disentangle when we're doing these meta-analyses. Are we looking at apps that are providing comprehensive intervention, or are they just focusing on a singular aspect of what we would do during intervention, like a self-monitoring app? And one note on to end the section on smartphone and internet, on a more positive note, there has been some work recently showing some apps. At first, it was just a bunch of, there were a couple pilots that had promising results, but there's now been a large trial of one of these apps that basically broke the DPP into small interactive modules, put it in a smartphone app, added some interactive components, and found outcomes that were more similar to what we'd see in an in-person intervention. And they actually had a in-person intervention as one of the trial arms and found no significant difference. So 7.5% in the smartphone arm and 8.5% in the in-person group treatment arm. So moving on to video conferencing interventions. In this first picture that I have up here, I do have to throw some history here and kind of talk back to the original studies in this area, which were done using ITV, which some folks on this Zoom call in this room might have never even heard of. It was interactive TV. We got super excited about it for a while too, in terms of remote intervention delivery. because similarly to the phone interventions, you could do intervention in areas with no trained interventionists. So these involved setting up TVs or media devices in areas that are centrally located so that folks could go there and basically have a group intervention. All the group members would be in person, but the interventionist would be remote via these technologies. Outcomes were really strong. They were similar to what we'd see in person. The only challenge was that they actually tended to be a little bit more expensive than the regular in-person programs, because then you're taking all these technologies out to rural counties, taking these technologies out to the city centers where they're community centers where they're being run. So they cost a little bit more. And so I'm not really going to go into depth, because while they're exciting at the time, we've now moved on as a world from ITV, and I don't think it was going to be using it for much. But it was informative looking into what we all do now. We'll recognize this. I mean, I would say most of the people on this talk today are on Zoom, not in person. We're all on Zoom a lot. So I'm going to talk about Zoom-based, this sort of video conference-based intervention. And pre-pandemic, not a lot had been done in this arena. There have been 3 small pilot studies. They all demonstrated weight losses smaller in magnitude to those seen in traditional in-person programs, but they're all just pilots. Several of them were in unique populations, like one was in a military population. There weren't any larger trials really looking at can video conferencing be as effective as in person. And so we entered COVID with no research on can this be effective, and then suddenly we all had to do it anyways. So I'm going to be talking today about some results from a study that we put out earlier this year, looking at outcomes from our ongoing trial. We have an initial weight loss program that was switched to remote delivery via Zoom due to COVID, and comparing some of those outcomes to historical data from our literature. So first off, to introduce the study that these data are coming from, it's called Project STAR to participants. This is our study logo. This is funded by the National Institute of Diabetes, Digestive and Kidney Diseases. But we are looking at evaluating an adaptive smartphone-based intervention for weight loss maintenance. So I mentioned earlier, maintenance is kind of my jam. I like to do a lot of work there. And so this trial, to implement it here in Gainesville, we needed to recruit about 250 people who had recently lost weight. There are cities where you can do that. Gainesville is not one of those. So in order to find 250 people who have recently lost weight, our idea was to first run a weight loss program and then recruit the folks who were eligible after the end of that program, or who had lost a clinically meaningful amount of weight. And so it's exactly what we did. We have a 16-week gold standard weight management program when we proposed to randomize anybody who lost at least 5% of their weight during the initial program to the maintenance trial, for the sole reason that we're studying maintenance. And so to study maintenance, we first need to have folks who have lost weight. And so today I'm entirely going to talk about this initial intervention period. I'm not presenting any trial results. The trial is ongoing. We haven't looked at the data, but we did have some interesting stuff from this first initial intervention period. And because it's not part of the trial itself, we can actually look at the data. And so if you're interested in this at all and have any questions about it, I'm happy to answer more questions about this trial, but I'm not going to give more detail here because it's irrelevant to what I'm presenting today. So the initial intervention, it was a group-based weight loss program, 16 sessions based on the protocol from the lifestyle intervention of the diabetes prevention program, as are most of our behavioral interventions nowadays. Each group had 2 interventionists, between 9 and 18 participants. And at the first session, participants were provided with a study e-scale registered with a study smartphone app to track dietary intake and physical activity. And the reason I'm giving some of these details is I'm going to link back to some of this later on. I do want to talk about this app for a second. I hate the name, Fat Secret, but for anybody interested in doing intervention work or clinical work, they allow academic researchers and nonprofit institutions to use this app completely free and to inherit it into your own app, which means that you can have access to all of the bells and whistles of a modern self-monitoring app like MyFitnessPal, like Lose It, without having to have the tech background to support that. So you can use their food databases, you can use their physical activity lists, the recipe builders, the barcode scanners, basically use all of that within your own app without having to do that yourself, which is great because the commercial side of things, they're much better at doing that than we are as researchers. I'm also going to talk about this scale for a minute because some of the other things I'm going to talk about later hinge on having a good way of reliably assessing weight remotely. And this is just one example of many smart scales that exist. In fact, I should have put it up here. Some of my trainees worked on a great paper comparing all of the self-monitoring technology and getting some clinical recommendations. And it has about 10 different scales on there that talk about the different prices and types. But this one in particular is what we use for this study. It uses the cellular network, which means that it doesn't require any setup from participants. Basically, people can take the scale home, put the batteries in. We don't really put them in for them, but I mean, you actually are currently, we ship them to people. We don't put them in for them. We used to. They set it on the ground, step on and off a couple times to make sure it's calibrated right, and then it works. As soon as someone steps on it, steps off, it sends the weight through the cellular network right back to research servers. Doesn't need any other setup other than that. There are other scales in the market that do require Bluetooth or having another device that it syncs to, and those tend to be a little bit cheaper. And 2 studies have demonstrated measurement concordance of this scale in particular with calibrated clinical scales, which is important for our outcomes to know that this is a valid and reliable measure. And both studies found about a kilogram difference between smart scale and clinic weights. And this is likely related to protocols of how they're implemented. In weight management trials, when we're working with people out in the community, we work on their schedule. We are as flexible as possible so that we can get people back in for follow-up visits. And so typically we'll have folks come in the late afternoon, evening when they get off of work, which is very different from when we use the smart scales. The scales that are at home, our protocol is ask folks to step on it first thing in the morning, after they wake up, after they go to the bathroom, before they've had anything to eat or drink. We recommend no more than light indoor clothing. A lot of people weigh themselves naked. But the nice thing about that is you get a nice consistent weight over time. And if you think throughout the day, as you're eating, drinking, time goes on, your weight goes up throughout the day. And so this variance is likely due to just we weigh people at different times of the day with these scales. But the nice thing is that 2 papers now have documented it, and you can correct for it if you need to compare between these measures. And I'm going to give those references here. So one of the study was done by my group, another study was done by Dr. Kurkowski at UVA now. And once COVID hit, a bunch of folks were contacting both of us, asking us how to use these scales because suddenly they needed to switch to remote operation. So we wrote a review paper or a letter to give instructions for how to implement these in research and clinical use. So if anybody is interested in using these sorts of devices, that's a good reference. Back to STAR. So our session content here, anybody who's worked on a DPP-based intervention, these session titles are going to look alarmingly familiar. We only had a couple modifications due to newer research in areas and just updating some of the outdated material. Our first cohort started in January 2020, which if you remember when COVID hit, was soon after. And so our first cohort switched to remote delivery right at session 11, which is March 16th. And we were very fortunate in this switch. We had pretty much no hiccups at all. Very rarely, you can ever see that in research. As was mentioned in my introduction, I also am in public health in addition to clinical health psychology. And the good thing about being in public health in January of 2020 is you started hearing alarm bells going off really early. And so I think when I started bringing this up at the lab meeting, folks thought I was a little like going overboard, but I was letting folks know, oh, we're gonna have a contingency plan. Thankfully, UF had just opened up a PHI compliant Zoom portal, maybe 2 months before that. We got really lucky. So I immediately started hounding the IRB saying, if this happens, I need to switch to Zoom. Is this okay? And got some temporary authorization. And once it happened, the day that they shut campus down, I called the IRB again and started harassing them and got the approval. And so we had absolutely no break in our sessions. We went right from in-person to Zoom and had very minimal technical challenges, I will say. It's one thing folks ask a lot, or do people run into technical difficulties? It's rare and we can almost always address it. We had very little challenge, and we've had even fewer challenges as cohorts have gone on, because I think a lot of people have ended up having to interact with Zoom, whether for other telemedicine appointments, for work, that sort of thing. And so cohorts 2 and beyond have been entirely remote. And all the data I'm going to present today are from cohorts 1 and 2, because that's what was available when we were working on this. And we're just in cohort 5 right now, initial intervention. And so the key question from this was, would outcomes be significantly worse in these two cohorts, one that transitioned to Zoom, one that was all done via Zoom, than those historically observed in gold standard face-to-face interventions? Like I said, the nice thing about our field is we have shockingly consistent results. And so we have a population mean we could compare to. And so we took a non-inferiority approach, which is from the clinical trials literature. Normally you'll have two groups, one that's a gold standard program and one that's a cheaper program or easier to offer. And you want to see, well, are the outcomes clinically inferior? And so to do that, you select a range of what you would consider a clinically inferior outcome. And so in doing this, we considered clinically meaningful thresholds for weight loss. Quite a few exist. There are some larger ones from HLBI and IOM in terms of health outcomes related to those weight losses. But those guidelines I mentioned earlier, the AHA, ACC, and TOS guidelines, are now highlighting that even at weight losses as low as 2.5%, we're still seeing clinical benefit. And so we tried to pick, well, what's the smallest weight loss that's meaningful, and go with that. And so that didn't line up correctly on this slideshow. It was right around the 2.5% there. The 2.5% is what we selected as our minimally meaningful clinical threshold. And so basically, to do a non-inferiority approach in this paradigm, we are able to take the 8%, subtract 2.5%, and basically say if our program was significantly better than 5.5%, we consider it non-inferior. So looking at some of our outcomes, our attendance was really strong. It got even better during cohort 2, and I'll talk a little bit later about this, but we heard a lot from participants that Zoom is just easier. You don't have to find parking, you don't have to drive across town, and we're not in a big city. Gainesville's not huge, but we still have some transportation challenges in terms of traffic getting to and from campus, parking on campus, having to walk from wherever parking is. Folks don't have to find childcare necessarily. Kids can be in another room versus having to have a babysitter. And so we found some better attendance. And we had this just for interpreting the results later on in terms of retention. I will note there's a little bit of a difference between cohort 1 and cohort 2. And this is because cohort 1, we were still mostly in save the trial mode mindset wise. The trial itself started after month 4 assessments. We randomized folks and then we follow up. We were spread a little thin staffing wise, all trying to figure out what was going on, building the plane as we flew it type situation that we were all in back in March. And so once month 4 assessments came for cohort 1, which was in April, we were focused on getting, because it was also our first cohort, which in a clinical trial is always the fun cohort. We were focused on getting our folks who are eligible for randomization set, randomized in the trial. We were not chasing down anybody who stopped showing up at the group visits, anybody who wasn't calling us to come back for the assessment. By cohort 2, we realized, wait, this initial intervention, we might be collecting some good data here. Let's go ahead and make sure we get everybody back in. So as we would in a normal clinical trial, we basically bugged people more at the end of month 4. Even if you don't finish groups, can you still come back to assessment? Your data is important to us. And so we had a higher retention there, and we have for our later cohorts as well too. And our weight loss outcomes, participants lost an average of about a little over 7.5 kilograms, a little over 7%. And I put this dotted line here so that you could see where that transition happened for cohort 1 to see if are there any time effects happening before and after that. We really didn't see any evidence of that. And importantly, this was significantly greater than that margin for inferiority that we had selected. In terms of our secondary outcomes, similarly, just to see like what's going on here. Do we see any difference in people's behavioral patterns? In terms of caloric goal attainment and physical activity goal attainment, we also didn't see any changes before and after the switch to Zoom for cohort 1. And the reason that physical activity starts at week 5 is that's when we started introducing physical activity goals. And so I'm going to switch now to talking about the fun part of the study that never gets in the paper, the kind of implementation, lessons learned from doing these Zoom interventions. One, we've learned to provide technical assistance early on. And so now in our current cohorts, when we recruit folks, we do our orientation sessions on Zoom. And that's when we start figuring out what problems are people running into, how do we help them fix those? So they're not session 1 of the intervention. We're trying to talk about weight management. They're trying to figure out how the heck to use Zoom. We want to separate that process. And so we do our technical assistance early on and make sure that by the time the first session starts, folks know what they're doing and how to use Zoom. It's really important to encourage people to maintain privacy. Sometimes folks might forget that it's important to not be in a public place. If there's somewhere where other folks can hear them, to have headphones, but to log in from somewhere private if possible. Not while driving, which was an issue early on, and we addressed that quickly as a safety issue. And really importantly, to keep cameras on. For anyone who's led a group intervention via Zoom or taught a class or just been in a group meeting, you know how kind of soul crushing it can be to look at a bunch of boxes that are just people's names. I'm not calling anyone out on Zoom right now, but it's challenging. And so to replicate that atmosphere that we have in an in-person group, we find it really important to have folks have their cameras on. We mentioned that before the first session so people aren't surprised, because some folks are kind of used to new Zoom norms of it's fine to have your camera off. And then we remind folks after that first session to please keep their cameras on, and we haven't had any pushback with that. We heavily encourage group discussion, and this is from our program in general, not just once we're on Zoom, but our program has always taken a more of a motivational interview approach using strategies from group therapy, really using like Socratic questioning more than didactics and lecturing, trying to get people to contribute ideas and joining group discussions early on in the program. And so we do that in person too. So on Zoom, we make sure to do it even more so. We start that very first session with the introduction, get everybody talking. And from then on, we're frequently throwing questions back to the group, engaging the group in discussion. And interestingly, one thing we did not anticipate at the start of Zoom was the use of the chat. We still haven't tested this at all. I don't think any interventions have looked at this, but the role of the chat has been really helpful in our groups because it's a way for people to, maybe they have something quick they want to say, but they don't want to interrupt the discussion. Or if you have someone who's a little bit more shy and doesn't feel as comfortable speaking up, that's a way to engage folks. It's a way to send a quick message to someone if you want to chat with them later. I'll mention in 1 second. But the chat has been really important. I think it would be great to see some research done in that area. And then as a security issue, using the waiting room to prevent people from joining. So there's a function on Zoom. So that way, when people join, they're in the waiting room and a host has to let them in. That keeps the sessions confidential and private. You can see who you have before you let them in, and keeps the Zoom bombing away. And then using breakout rooms before and after session has been very successful in terms of checking in with people individually. So I mentioned the chat function earlier. Say somebody says something during group that you really want to follow up more on, but don't want to pull the group attention towards it, or use that group time. You can send someone a message and ask them to stay, put them in a breakout room and talk with them one-on-one afterwards. Or similarly, if you see something concerning in someone's self-monitoring data, you can ask, hey, can you come to group early next week? I just want to chat with you real quick, put them in a breakout room and talk with them. That's been really effective. So some take-home messages here. Adults with obesity completing a DPP-based weight loss program that transitioned to Zoom during COVID. The reason I'm talking about during COVID is I didn't even mention this, like we're also doing this in the face of a global pandemic that we know has affected people's health behaviors. Folks who are suddenly working from home were telling us it's a struggle not to just eat all day when I have the kitchen right there. Folks are saying, well, it's hard for me to get up and get my steps in because all I do is walk from my bedroom to my kitchen to my bathroom instead of having to walk around a campus or walk around an office building. Conversely, folks who were first responders were telling us, I am completely out of time right now. I'm working back-to-back shifts because we don't have coverage. I don't have time to cook. I don't have time to be more active. And so there were challenges left and right for folks. And so despite that, we're still seeing a clinically meaningful amount of weight loss. And it's actually almost the same as the initial body weight loss we saw during the DPP trial, which was 7%. These were non-inferior, because I just mentioned to the 8% typically observed and similar to those in the DPP trial. And a paper came out not long after ours too that found similar weight losses in their 16-week intervention, about 7.5%. And so taken together, this shows that behavioral interventions are pretty robust, thankfully, to transitions in delivery format and even to global pandemics, and that people can experience clinically meaningful outcomes despite all this. And this is important because we're seeing now that some people really prefer video conferencing. And this isn't something that's likely to limit who we're able to reach, as most people have smartphones now, and there's really no difference by race, ethnicity. There are some differences in terms of rurality and income, but even those are very minor. And I'm going to talk a little bit about some of the work that I've done looking at people's preference for video conferencing. And the first study was done with colleagues here, looking at, this was early COVID, this was April 2020, figuring out what was going on with folks taking part in behavioral interventions at that time. So we conducted a survey with participants in health-related research studies using Research Match, sending it to participants in our trials, colleagues who we knew were running trials, and collected data during 2 weeks in early April 2020. Got about 250 people, age, not as many of the older folks, but kind of balanced, and then looking similar to our samples in behavioral weight management literature, primarily women, primarily non-Hispanic white individuals. This was a decently highly educated sample too for context of interpreting these results. And most participants were a little or extremely hesitant to attend in-person visits at this point. Most people didn't think taking part in research was an additional risk, and it didn't affect desire to participate in research. And the reason I bring this up is at this point, we had just finished cohort 1. We were trying to figure out, do we even try to recruit a cohort 2? Do we just try to wait till this is over, as everyone kept trying to do for a while? And this encouraged us to go ahead and like, well, people still want to take part in research. People still want to take part in these interventions. And so we started cohort 2 recruitment not long after these data analyses. And there were some qualitative results, and I'm looking at the time. I'll go kind of quickly through these. I'm going to focus just today on these 2, and you can read the paper if you're interested in some more of the transition to remote delivery and the impact. And we found that at that point, and by April, it was a month into the pandemic, most people have been transitioned to remote delivery of intervention. Some people noted technical difficulties, but most reported very little impact. Interestingly, some of the impact, that bottom one, was I'm more bothered that other people are having technological challenges because it was interfering with intervention. And some of the impacts that we were seeing were just related to COVID. So folks saying, well, I can't practice what I'm working on in real life because that wasn't real life. They weren't going out to social situations or doing activities they normally engage in. And then for remote delivery, we heard that people missed support and connection from in-person visits. So it can be a little tougher to get that human connection. Some folks say I dislike participating virtually. The technical aspects can be stressful. Zoom group meetings can be extremely boring. And so this is just emphasizing the point that we need to really put in the work to make these group sessions interactive, help people feel like they're part of a group, and then they're not just sitting on another Zoom call with 20 other people and not really engaging. And we also heard that at this point in April already, some people reported preference for remote delivery. So folks saying, well, we hope you keep doing this longer term. And so that prompted us to follow up later on. We did the analysis for this first paper in July or so. And so in September and October, we did a second follow-up study of these participants and really try to dive in more into how folks were doing then, but also looked at preference for intervention delivery modalities. And that's what I'm going to present here today. I'm just going to focus just on that. But we found at that point that when we asked people what they preferred for behavioral interventions, and remember, these are people who are in trials of behavioral interventions, now and then moving forward post-pandemic, that people preferred video conferencing. And we heard some of the same things in some of our open response questions, that they're just easier to get to the visits. You don't have to worry about driving, parking. In person was a close second, and then there's some preference for the other ones. And these don't add up to 100% because people could indicate more than one here. And so moving forward, for our study now, we're doing everything on Zoom. We've fully committed, we're in it for the long run. And this was really enabled because of those remote assessment procedures too. We are now, as of cohorts 4 and 5, testing the waters for some future rollouts of, can we make it so that people don't ever even come in? Can we do everything completely remotely? And it's been very successful. So we've done that and expanded our recruitment to Jacksonville and surrounding areas, basically places where if this didn't work, can we go send a mobile team out to still do assessment and it be reasonable? But it's gone really great so far. And so for future studies, we're really going to eye national recruitment. There's really no reason now. And in terms of broadening reach and disseminating these programs, there's no question that this is going to really help us increase access to care, because it's not just us. In talking with colleagues, this is what everyone's looking at moving on. And then also, I think a key takeaway from this work is to move forward, and it's something I've been doing, and I encourage other folks to join in. We talk a lot about advocacy in science, but I think it's an important role we can play. But advocating for increasing coverage for remote and telehealth interventions from insurance companies and from CMS. In a particular area that this might be important is CMS, Center for Medicare and Medicaid Services, has a national diabetes prevention program. So that intervention I mentioned, the 16-week gold standard lifestyle program, they've been disseminating it nationally. One challenge is that we, with Dr. Perry here and a couple of our students a couple of years ago, we did a paper and we're looking specifically at rural dissemination due to the DPP. And we found that unfortunately, disparities actually increased after this dissemination, because what we found is that NDPP sites were opened up in places that already had access to treatment. And so it's kind of one of those rich get richer type situations that there was now even less relative access in rural areas. And so remote intervention in this program is a really important avenue for recruiting in those areas and in getting people enrolled in those areas. So there was a position statement that we put out in June of last year. This is working with some colleagues of Society of Behavioral Medicine. And we called specifically for legislators to fund NDPP in person or virtually, because it was being funded in person, but not virtually. And during COVID, there was a temporary allowance for programs that were ongoing to do some virtual intervention and get reimbursement, but that was not expanded. There was an act that unfortunately died in a Senate committee, but it's been reintroduced twice to improve access to Medicare. So there's a Medicare diabetes prevention program as well for anybody enrolled in Medicare, also not available remotely. But this bill in particular was to expand that to virtual settings. And so, although there was expanded support for telehealth and telemedicine in this 2022 CMS physician fee schedule, the Medicare diabetes prevention program was specifically excluded from that coverage. And CMS still does not reimburse for remotely delivered versions of the National Diabetes Prevention Program, despite the existence of data now showing that these programs work just as well. And one of their worries for a while was, how can we know that people are actually reaching the outcomes that we're looking for? We have smart scales, we have the technology to be able to objectively measure weight from afar. There's really no reason. So I'll keep hitting this point. But perfect timing. So I'll go ahead and wrap up really quick, leave a couple minutes for questions. But just to kind of some take-home points, prior to the pandemic already, there was evidence supporting remote intervention delivery, not necessarily for Zoom specifically, but telehealth through the telephone and through internet and ITV. But there's work to be done here. We need to make sure that our programs are producing equitable outcomes. We need to improve smartphone internet programs. These are the programs with highest potential for widespread dissemination, because so almost everybody has a smartphone now, 85% of the population. It's increasing every year. And that number was from 2 years ago. Pew hasn't done another survey since. But there's a lot of work to be done in that area. And our lab is doing some neat work there. Outcomes of weight management interventions transition to Zoom during COVID were similar despite COVID and despite that transition. And then phone and video conferencing technologies offer high potential to broaden dissemination and reach of behavioral interventions for adult obesity, but coverage remains extremely limited. And so I think that's an important place that we can advocate for future coverage. And I would end just by thanking everybody involved. First, the folks who fund us and support us, NIH, NADDK, and NHLBI, UF's Department of Clinical Psychology and Lifespan Corporation in Providence, Rhode Island, my collaborators here at UF, at Brown and UVA, and then my wonderful lab, my team that keeps everything afloat with this large clinical trial that we're still running. I am very thankful to all the work that they're doing. So I will end it here, and I'm happy to take questions if anyone has any.
Thank you.
And I can't see the chat, so.
Yes, I'm keeping track here. So I don't know if they can hear me, but please unmute if you would like to ask a question. Haven't received anything. Yeah.
We don't know if the sound traveled, so please unmute and ask a question. And I can't see the chat.
I can read it some other times. I'm not from the scientific researcher group, adult general population question. During the pandemic, I went through very similar, gained some weight, pantry and fridge right there, having a glass or two of wine every day. But anyway, after that, I thought, you know what, I have to, get back on track and exercise and pay attention to what I eat and all of that. I did all of that myself, but we're always looking for that perfect formula. Which shake, which equipment, what kind of activity or whatever. But I see there was like a consistent improvement of weight loss during the intervention, during those sessions. I don't know if I missed, after those sessions ended, do you have data that after like 6 months or a year, how that group, how did they like, were they able to maintain, to keep it? They lost track again and gained some weight. It seems that it was very effective and virtual, which is also I prefer. Like I need twice as much the time to go to a doctor office or to the gym, so I just prefer to do online. And the results were great, significant. But how about after those sessions? Do you have any data? How did they?
Yeah, I'll repeat the question quickly, just so in case folks on Zoom couldn't hear. It was asked about data after the initial intervention. How are folks doing in 6 months, 12 months later? Unfortunately, we do have that data. I haven't looked at it because that is our trial data. So after that initial program, folks were randomized to one of 2 extended care programs. One was a monthly check-in with the interventionist, so similar to kind of our gold standard approach. The other was building on some data analyses we did from a prior study. We built a predictive algorithm that with about 80% accuracy can predict whether someone's going to regain weight next week. And the idea with that was, could we trigger extended care intervention and provide it just when people are at high risk? Because it's likely not that 1 week out of the month. And then when folks are doing well, not bother them. There's kind of that 2 sides to it. And so that trial is what's actually funded. The initial weight loss program was just a long run-in period for that trial. And so we won't have our final data until 2025, unfortunately, because the long time of clinical trials. But
because that was leading to my next question is like, what's the secret formula? How often you should meet those folks so everyone stays on track? Is it monthly? Is it quarterly? To kind of reinforce and go over it, so don't let people, or maybe with this data, like you said, it could be something even more interactive. Like if the data is collected, can you create individually like plans, like, oh, this person needs a weekly reminder, this one every quarter is fine. So maybe you can develop a system that could be more effective too.
Yeah, that's our hope going forward. We are finding that some folks do need a lot more contact than we expected initially. There are some folks that trigger every single week. And so moving forward, we'll be doing work of like, maybe they don't need a phone call. Maybe they could have some lower intensity interaction early on. And then kind of triage up for sustainability reasons, because we can't call people every week. No one's going to pay for that. They want to pay for what we have right now.
Well, but AI and all of that, you could be using. Yeah,
so there's actually, I just sent a grant out for an AI driven approach for that, for providing that initial feedback or the maintenance feedback. But yeah, that's really the hope. And so right now our gold standard is monthly, because that's what we've tested. We don't really know whether more frequent or less frequent. There has been some work in doing campaigns in terms of maybe we don't meet with folks for a couple weeks or a couple months, and then we do like 5 sessions all at once. And unfortunately, there's been some challenges getting people coming back to those. So maybe having the like once a month might help in terms of staying connected with folks. But even those, we start to see a decline in attendance over time. And part of it might be that if it's not effective, I mentioned before that 1 week is likely not the week they're running into trouble. And so if folks are running into trouble and viewing those calls as not helpful, then they're not going to keep coming back. And so we're hoping that triggering that intervention scheduling for when people are at higher risk will help. We'll see at the end of this, the question of the grant. A lot of area for neat work moving forward.
I didn't get any question here. Anyone else?
Is there any concern, taking it predominantly all online, where there could be the possibility where it's still like rich getting richer? Because I mean, there are still areas where internet is not available in a household, or even households that, I mean, 85% of people have a smartphone, but you know, people have 2 smartphones. There are some households, and just so is there? And it's probably a bigger question than could even be answered, but you know, what about? Are you concerned about that missing population as well?
Yeah, that's a great question. So just to repeat it in case it couldn't be heard, I don't know if there's mics back there actually working on. There was a question asking if we're doing these national studies and these online interventions, are we missing people and doing that keeping richer type dissemination where we're not accessing folks who might not have that technology? That's a great question. I think there's kind of 2 answers to that. One, there's just been such rapid involvement in terms of access and even some of the broadband work that's been done under the recent administration and improving access in rural areas, I think in response to COVID. And there are a lot of areas in terms of people can go to libraries, people can access the internet in other places. So I think having something smartphone only might limit it, but I think that it'll probably be very temporary, because I think that the preponderance of unlimited data plans, of the cost efficiency of those data plans, it's really becoming widespread. With that said, I think there is a huge potential to only reach folks who are high income, high education through traditional recruitment means online. And so as a completely other arena that I think is really important to pay attention to is how we recruit people for programs and how we bring people in. My project director, Ina Shankar, is working on an abstract right now for us, Society of Behavioral Medicine Conference, looking at our recruitment, because that was one of the challenges we faced. We do a lot of community-based recruitment. And suddenly we're on COVID time and we can't do our in-person stuff. So what do we do? And we actually found that our traditional in-person recruitment methods translated extremely well to remote formats. And so we do a lot of visits with churches. We talk a lot with pastors. We'll go to services. And we found that worked just as well. A lot of churches were doing Zoom during COVID or have newsletters, and we're still able to connect with the pastors. We're still able to get the word out there through churches, through community organizations in a similar way. I think more people are looking at community mailing lists and getting information virtually. And so I think the issue there is less related to the delivery modality, more to how we do outreach in terms to enroll people. But I think it's incredibly important to pay attention to, because if you don't, only people that already probably have resources are going to be the ones enrolled in those programs.
Yeah, I don't see any other questions. Dr. Berry, thanks for the presentation.
Yeah. Great, thank you all. Sorry, we ran a little over. I think we had a late start, but we worked it out.
Thank you, appreciate it.
Thanks. No one came in and charged the room.